Thanks for participating in this depression education program. This module contains information about depression in older adults. Maybe you're wondering why we should worry about depression when there are so many things that already need to be done for the residents each day. When you're taking care of older adults, you worry about their blood pressure and oxygen levels, about their bowel and bladder care, their pain levels and safety. These things are always on our minds and we monitor these each day. But what about a person's mood? How often do we watch for isolation or changes in their sleep habits or changes in their eating pattern? The goal for this class is to learn about depression and how it affects the older adults we work with. Then we can gain some skills that will help us identify depression symptoms and better support and care for these residents in the assisted living. So how common is depression? More common than we think or talk about. In 2019, the population in the United States over age 65 was about 54.1 million, or 16% of the population. In 2030, that number will be almost 66 million. In the community, between 5 and 10 million older adults have depression, and the rate is almost twice as high for assisted living and other long-term care settings, making it even more common than in the community. There are almost a million older adults living in assisted livings, and of all the diagnoses you'll see, depression is one of the top 5. So why do we worry about depression? It's easy to see why we worry about weight and blood pressure and the physical vital signs that we gather on the residents, but why worry about mood? So older adults with depression have a harder time sticking with the medical treatment plan, and that increases their chronic condition and lead to mortality. When older adults are depressed, they tend to use medical and social services more. So a depressed older adult might be more likely to go to the ER for an issue than one that isn't depressed. Suicide rates are higher in older adults and other age groups, and major depression is a risk factor for suicide. And just overall, depression affects a person's health and quality of life. It affects the way they interact with others and how they view what goes on around them. So an older adult with depression might be less likely to tolerate food they don't like from the kitchen at their meals, or taking a little bit longer to answer a call light. So depression can really affect how they perceive the care they're receiving and how they interact with you as caregivers. So who are we looking at? Who's at risk for depression? In the assisted living, it's kind of easy to see that all the residents could be at risk for depression. So risk factors, of course, include personal history or family history of depression. And although it's not that common, drug and alcohol misuse puts them at risk for depression. And then there's the things that we see every day. So physical disability, chronic medical conditions. When they're worried about finances, can't pay their bills, and have low income, that can lead to depression. The changes in the social supports, like when somebody they love dies, or when they move away from their home that they've had for so many years into assisted living, then they've moved from friends and family. So that change in their support network can lead to depression. The change in their living arrangements. So that has to do with having less control over their lives, less control over what they eat, when they take a shower, the fact that somebody has to help them. All of those things we see as we're helping them, but sometimes they see it as a loss, and that can increase their risk for depression. And then the last one is maybe kind of vague. So we all enjoy being out in the community and doing things and feeling accomplishment when we do something, maybe success. But sometimes when someone's in the assisted living and they have fewer contacts and they're not doing as much, they lose that opportunity to feel successful. And that can increase their risk for depression. So if everybody's at risk for depression, how are we going to recognize it? Say we want to use depression as a vital sign in the MAR and track it each day. So what are we looking for? Remember, this isn't a diagnosis. We're not diagnosing them with depression, but we're only looking for warning signs that maybe we need to spend a little more time with this resident or report what's going on to the nurse or to the primary care provider. So common risk factors are cognitive issues. They are more forgetful, and this is hard because you also see dementia, but we're looking for more than just one thing. So they're also going to have more body-wide symptoms. They're going to have more vague pain, more aches, just overall not feeling as well. They can have some anxiety. You're going to see that maybe they lose interest in things that they liked before and they just don't care about it anymore. You can find that they sleep too much, they don't sleep enough, they're all of a sudden up more in the middle of the night. Maybe you notice that they're not eating as much or they're eating a lot more, and so you get an appetite or a weight change. They might all of a sudden have a decrease in energy. And then you have to listen to what they say. They might report feeling sad or feeling hopeless or all those feelings that we associate with depression. So when a resident shows signs of depression or is diagnosed by their clinician, what do we do next? Is it something they just live with for the rest of their lives, or can we help with treatment? So the best treatment is psychotherapy, which is like meeting with a mental health therapist or doing a group therapy, and then an antidepressant if they're willing to take it. One thing is depression, and all mental health illnesses kind of have a stigma. So sometimes a person could be told, well, I think you have depression, and they don't want to believe that. They're very embarrassed by that, so they're not going to seek treatment. There's a lot of things that make people resistant to talking about depression. So if we educate ourselves and help educate residents that, this is a medical condition and it doesn't mean that you're a weak person and there's help out there for this, then they're more likely to seek some treatment to feel better. So treatment involves referring to primary care for medication, mental health care for therapy, and then sometimes social services. So our focus in this program is behavioral activation. So this is a psychotherapy that helps a person who has depression to think about what they do each day. It's focusing on their inactivity. And then we look at, well, what did you enjoy? What do you value? So then we're making a list of activities they could participate in. And then they choose an activity and try to do it. So it's pretty easy to teach, but it requires a lot of support, especially at the beginning when they're just starting to become more active and trying to break out of that isolation and that depressive cycle. So that's where the staff at the assisted living comes in and being supportive and recognizing, oh, this is what they're trying to do. They're trying to become more active. They're trying to overcome their depression, and we can help tell them that this is a great thing. You can keep going. Let us remind you about these things. So in the next modules that we'll go through, we'll talk a little bit more about how to work with older adults, how to talk to them about their depression, how behavioral activation works kind of in depth, and just give you some tools in your tool belt that can help you with the residents and their daily care. Thanks for listening.